to thank you all for joining. I'm looking at the chat module and I see we have people joining in from Asia, saying hello from Asia at all kind of hours, Europe, South America, all over US. It really is a pleasure to spend the next hour or so with you right now. It is going to be a great opportunity for us to connect. I cherish these opportunities far more during this period where we're all confined to our homes to connect with our colleagues and friends and work on our personal and professional growth. I know that all of us right now are in a very dark period, and this is really quite tragic as what's happening in the global health at this point. I know that specifically for our dental colleagues, this is a very dark moment because we're all confined to our homes. We cannot be doing what we love to do, which is treat our patients and be with our team members and practice the profession that we love to do. But this opportunity to connect using these educational connections is a great way for all of us to work on our professional development at this point, but also network and connect with colleagues so we have more of connection at this point. I know that it is going to be a period of time before many of us are back to our professional work environment, but this is actually something that may be very positive for us to do all the things that we have always had the passion to do, but we never had the time to do that. So I'm hoping that all of you are remaining healthy, your families are healthy, you are working in some capacity to enhance your skills, your knowledge, and working on professional development during this period. Because I can tell you that at the end of all of this, we're going to go back to work and we're going to find some of us who, you know, among our colleagues who may use this period to just sit in front of a TV and couch and be, you know, physically out of shape, professionally out of touch, and, you know, financially in trouble. But others use this period for development and growth and you know, picking up new skills, developing and growing ideas, innovating. And those are the ones who are going to be at the end of this best suited for succeeding, because my dear colleagues, we're going to be in a different world tomorrow than we have been in the past. And it's anybody's guess how tomorrow will be, but we can all play a part in that. So with that, we want to get to our topic at hand, which is VISTA, and how we could utilize VISTA for our professional, you know, treatments in treating soft tissue and bone regeneration. So I'd like to first start by making a disclosure, because I think it's very important that we all are very transparent in the way we conduct ourselves. And I would like you all to know that I do have financial interest in the company called Regenimune, which manufactures a number of products that I will discuss today: the fixation screws, the sutures, the VISTA instruments. Some of these are you know, are distributed by Piezo Surgery. Some is distributed through our own company, and also I have had you know, honoraria from several companies, Ishik by Horizon Piezo Surgery and our VISTA Institute. So these are all areas of potential conflict of interest. I just want to be very much transparent about these disclosures. So we come across many patients who have soft tissue and hard tissue deficiencies. These could manifest themselves in the form of gingival recession defects, sometimes single defects, but more often than not, multiple recession types of defects. So we also have patients who have papilla loss, those patients who are going to require tooth extraction, and we need to manage not only the bone, but also the soft tissues around those areas. Patients who have healed sites that have resorbed and have atrophied and are in need of reconstruction, so we can augment with bone or soft tissue. Implants that are not in the ideal position, implants that are placed maybe too far facially, too far apically, and if you were to restore them, we're going to have not the most pleasant contours. The soft tissues around our restorations of teeth or implants that are unesthetic and deficient and require some treatment, and also mucosal deficiencies around our implant. So these are all situations that are amenable to treatment by techniques that we call periodontal plastic surgery. The field of periodontal plastic surgery was opened by Pat Allen and P.D. Miller, who first coined this term of periodontal plastic surgery. Later, this has been expanded to include peri-implant plastic surgery. So I hear that there's an echo here from my phone. I apologize for that. So we have patients with recession defects. Some of these recession defects could be minor, some of them could be major, and some of them could be generalized. Let me just go ahead. I think my phone is, I have that running just to see how it looks, but maybe I'll mute that if I can. Yes, I was able to mute that. Okay. So, sorry about that. So, treating gingival recession defects is a major problem for us, so I'll address that first because this is a very common problem. So, how are we doing with treating gingival recession defect? This publication that was published a couple of years ago by my good friend Leandro Chambron, this demonstrated basically progression of developments in this field. Basically, it charted all of the publications on root coverage techniques and the percentage of root coverage over time using different types of grafting techniques and materials. But if we basically are looking at the totality of the publications on root coverage, this is the chart that we see. When we go from the 1990s to the late 20-teens, we're going to see a progression of improvement in the outcome of root coverage. That is great because back in early 90s, the mean root coverage was less than 60%. Today, the mean coverage is around 83%. Well, this is what we see at totality. But when you look at this chart, you see some studies that have very high success rate, root coverage in the 90s or close to 100. And then you see some studies that have, not so great root coverage. What is the difference between these two kinds of outcomes? You're going to say, well, maybe some are more honest than others? No. I think that it all depends on the types of cases that are selected. Many of the cases that are being published are highly selected, in single recession defects in very easy areas to correct, but also a lot has to do with our understanding of the risk factors and how to manage those. The question I'm going to ask you is whether or not that 83% mean, is that our ceiling? Is that the best we can do as professionals, or can we do better? And how can we move up to this category of having better outcomes compared to the category that is below with less than adequate outcome? Okay, so let's see. Well, how we can do better is by understanding the risk factors. That is one thing that has led us to have this progressive improvement in the outcomes, going from the lower percent root coverage to better. So what do we know based on scientific evidence? What we know is that patients who have a thick flap, basically those who have a thin mucosal phenotype versus thick mucosal phenotypes, have different outcomes. And studies have shown that when you compare these two, those who have thicker flaps and basically thicker mucosal phenotype have better outcomes. What is the difference between thick and thin? And these studies show that the cutoff is somewhere between 0.8 to 1.1%. We round it off and say we'll consider 1 millimeter or less to be thin mucosal phenotype. More than 1 millimeter will be thick mucosal phenotype, and that will determine our likelihood of success. Another predictor is flap tension. How much tension do we have when we try to reposition the gingival margin to coronally advance? And this study by Prada clearly demonstrated that when we take measures to reduce flap tension, so now we have lower tension when we're coronally advancing versus those sites that have high tension, lower flap tension leads to better outcomes. So any type of measure that we can take to reduce our flap tension could help us in achieving better outcomes. So what shows dramatic difference is where do we position the gingival margin at the end of our coronal advancement? Because how and where you position the gingival margin can dictate the outcome. This study shows that if the gingiva was placed right at the CEJ after coronal advancement, the likelihood of root coverage was only about 15% complete root coverage. If the gingival margin was placed more than 2 or 2.5 millimeters coronal to the CEJ, the likelihood of achieving complete root coverage was 100%. And if the gingival place was placed somewhere in the intermediary position, intermediate results were obtained. So this shows that if you want to have the highest level of root coverage or more likelihood, we need to position the gingival margin at least 2 millimeters coronal to the CEJ. My dear friends, not all techniques are amenable to that much coronal advancement. This is also a breakthrough information that came to our understanding, and this was a result of work done by Alfonso Gil, who is right now at the University of Zurich. What Alfonso has done for his master and eventually his PhD thesis work was to understand some of these risk factors by taking the study models of patients before and after root coverage, superimposing those three-dimensionally, and then slicing and dicing them to understand what were some of the risk factors. One of the most important risk factors that Alfonso was able to identify in this was root prominence. Root prominence, we all know as clinicians, is very important, but we haven't been able to always measure root prominence until Alfonso was able to superimpose before and after, and then he was able to physically measure the portion of the root that is extending outside of the gingival housing, okay? And what he found was a dramatic effect of root prominence on our ability to achieve root coverage. So what he found was that the higher the root prominence, the lower the root coverage achieved. So he was able to show that in those sites that had very little root prominence, that was less than 1 millimeter, these are basically flat roots, okay? Our ability to achieve root coverage using the VISTA technique was different than those sites that had more than 1 millimeter of root prominence, where a significant portion, more than 1 millimeter, was extending out of the gingival housing. In those sites that had flat roots, less than 1 millimeter of prominence, 110% was the mean root coverage achieved. Pretty good. Those sites that had more root coverage, more root prominence than 1 millimeter, a significant portion, more than 1 millimeter of the root was extending outside of the gingival housing, we were only able to achieve 70% root coverage. So same technique, but different, risk factor, which is root prominence. So this, my dear friends, is something that we as clinicians need to pay much closer to attention, and we need to quantify it, and we need to, measure it. You can see the root prominence in this case is definitely 2 to 3 millimeters. Basically, 2 to 3 millimeter of the root is extending outside of the gingival housing. So yes, we need to identify it. We need to tell our patient that this is a challenging situation. And then we need to do something about it, which is to perform odontoplasty. Odontoplasty means that we're going to flatten the root so that no portion of that root is extending out of the gingival housing. We can do that by removing restorative material, in this case composite. We can do that by flattening the surface of the dentine. But in extreme cases, we may need to do orthodontic therapy to retrocline the roots and move them inward. But this is going to determine how successful we will be. You can see pretty severe recession defects. After odontoplasty and VISTA root coverage, we were able to get 100% root coverage. So this is going to be the secret sauce. Don't tell anybody, okay? This is our secret. So what techniques are we using for treating gingival recession defects? We are using periodontal plastic surgery techniques. So Dara, if you could launch the poll, because we have a poll to see what techniques are you currently using for treating gingival recession defects more commonly. So if you could address that poll, we'll later announce what techniques as this group of participants are using right now. I think that would be of interest to me. We have the option of using free gingival graft. This is a free gingival graft is a classic technique in periodontal, techniques. I know some of my periodontist colleagues are so passionate about this that they believe that you cannot be a periodontist unless you do free gingival grafting. I can tell you that I wouldn't want that in my mouth, okay? But it's not wrong. It's not a mistake. It's an excellent technique, but it has some limitations that we'll describe. One of the most common techniques today is intracellular tunneling, creation of a tunnel through the sulcus of the teeth. Then we have coronally advanced flap. Coronally advanced flap, or CAF, is perhaps the most common technique today. And then we have VISTA, vestibular incision, subperiosteal tunnel access. You know, admittedly, I am biased about one of these techniques, but I will explain why I would prefer VISTA over other techniques. So let's look at free gingival grafting. Free gingival grafting definitely has advantages and disadvantages. What are the advantages? Advantages are that it is excellent for increasing the keratinized tissue width, increasing the thickness of the tissue. It works fantastic for that. No other technique, I think, it does better than that. The disadvantage is that it is limited for root coverage. We can see that there's a patient with generalized recession defects, putting this little tire patch in one spot. What is that going to do for this patient? Okay, it's not going to really help that patient. It also has donor site morbidity. I know I've had FGG in my mouth over 30 years ago. It's hard to forget it. It's pretty invasive. And there's a mismatch of color. You can see the color is usually lighter, whiter. The color difference in texture, you can see the rugae here. If you look very closely, you may see the uvula hanging from that. And, you know, it just doesn't look right. So if we are talking about plastic surgery, periodontal plastic surgery, can you imagine going to a plastic surgeon and they took a skin graft from whatever part of the body and putting it on your face to try to treat some form of a skin lesion on the face? It's not going to happen today. That's not plastic surgery, okay? Then other techniques have come along. The coronally advanced flap. Coronally advanced flap is perhaps the most investigated technique that we have, because there have been many, many studies that have been published using this technique for root coverage, and we know a great deal. Excellent clinicians have devoted to developing and improving and refining this technique. I know many excellent clinicians who are getting fantastic results with this technique, okay? But it has some limitation in that we are making incisions over our treatment area. Again, if we're going to a plastic surgeon and we want to get a facelift, would they put incision right in the area that is the subject of treatment? No. Plastic surgery today is about remote incision and tunneling, okay? Because remote incisions will hide the incision points in other areas. Well, the other technique that's available, intracellular tunneling, makes an incision that's internal. It still uses an incision. Some people want to believe that intracellular tunneling means incisionless. There's no such thing. This technique involves making an incision. The incision is internal, but then again, the incision is not remote. Incision is exactly in the area that is being treated. What do we do when we make an incision? Anytime you make any incision anywhere, we're going to compromise the localized blood supply to that area. So if we make an incision, we compromise the localized blood supply, we're going to compromise the healing in that area. One of the principles of plastic surgery is preserving the blood supply. So that's why making remote incision is better than making localized incision. Now, I know that there are some techniques who say they have zero incision, incisionless, okay? But, you know, it depends on how you define an incision. Once you perforate into the tissue of the human body, that is considered an incision. So if you want to make yourself believe that it's not an incision, but if you're perforating human mucosa, it is an incision. So personally, I would prefer to use a sharp 15C blade, make an incision in a remote area rather than, making incisions either locally in the site of that is being treated or making it by puncturing instrument through. So when we're talking about coronally advanced flap, the incisions are made in the papillae. So to me, if you make an incision in an area that is being treated, that's going to compromise the blood supply. We can see immediately after these incisions are made, there is some ischemia created in the gingival margin, and we can see the ischemia further along as the area is being sutured. So ischemia will impact our healing. Please take a look at some of the publications in all of these areas, and you'll see that there will be ischemia, and when we have ischemia, we're going to have compromised healing. Okay? So the advantages of coronally advanced flap is that it's a relatively simpler procedure because we're making an incision, that's pretty fast, we're reflecting the flap, but the procedure is a little bit simpler than other techniques. Disadvantages is that it compromises the blood supply in the exact area we're trying to reconstruct. And it has a propensity for creating scar tissue because the scar tissue is in the exact area that we're trying to make aesthetic. But also, the suturing technique is by sling suturing, which basically relies on slinging around the tooth. So as there's movement, it's not real stable. Because remember, our patients go home, they're going to be talking, they're going to be eating, they're going to be chewing, they're going to make facial expressions, and it's going to move our surgical field. Remember, wounds that move, micromotion is going to create scar formation rather than true regeneration. So along have come the technique of intracellular tunneling to minimize surface incision. But my dear friends, these are still incisions. They're not on the surface, they're internal, but they're still involved making incisions and still involve making the dissection. So for me personally, if we have to work through a small area to create that tunneling and the incision, the propensity is to make more errors and laceration and trauma. So this is a challenging procedure because as we work into the small hole, we're going to create more trauma to that gingival margin, the exact area we're trying to reconstruct. And also, again, the suturing technique is more challenging because it's not really as stable. And these reflect in the outcomes. So the advantages of intracellular tunneling is that there's no propensity for surface scar formation because these are actually, there's no surface incision. But the disadvantages are that it's technically challenging and there's a potential for trauma to gingival margin. And it has unstable coronal positioning. So personally, I would prefer to make a remote incision using vestibular incision, okay, sharp dissection, and then making a subperiosteal tunneling, which is basically full thickness dissection, because when our incision point is remote from the area of that we're treating, you see there's less potential for creating trauma in the area that is being treated. And the papillae, which are the areas that we're treating, we're not making incision right in the center of those. So to me, there are distinct surgical and biological advantages for VISTA. So I'd like to take you in more detail through one clinical case just to illustrate the steps and our protocol for VISTA and describe some of the rationale. So what are we seeing here? We see multiple recession defects. We see interdental tissue loss, which according to the current classification of Chiro, that means Chiro class 2, RT2, or the old classification of Miller class 3, because there's interdental tissue loss, okay? And some of these are pretty big black triangle. Now I know some colleagues are really promoting papillar regeneration, reconstruction, and we have to wonder how successful we are with that. Also, we can see that there are large restorations in the cervical areas, composite, as well as a PFM restoration. So we're going to use VISTA, stands for Vestibular Incision, Subperiosteal Tunnel Access. Okay, so first thing is that we're going to define what is our receded area, recession area, CJ to the roots. Our first step is to make a vestibular incision. The second step is to make subperiosteal tunneling. Why subperiosteal? Because when you keep the periosteum and mucosa together, you're not disrupting the tooth. Because if you're doing sharp dissection of doing supraperiosteal dissection or split dissection, you're going to disrupt the blood supply between periosteum and mucosa. By keeping the mucosa and periosteum together, we're preserving that blood supply, okay? And technically, it's much simpler. We extend our subperiosteal tunneling, not just to the vestibular side, but we go under each of the gingival margins. The next step is to perform odontoplasty. This is what we describe as the risk factor identified in Alfonso Gil's work, that risk factor for root prominence. So what are we going to do? We're going to perform odontoplasty to flatten these roots and remove every type of restoration that is on the root surfaces. So we are going to remove the composite, we're going to remove the porcelain. You see here, we have a pretty prominent restoration. So to my restorative colleagues, when you restore in these areas, you know, try to make the restorative margins less bulky around the cervical areas because it can be kinder to the tissue. So in this case, I removed all of that restorative material from the root surfaces and brought the restoration at the level of the CJ. I informed the patient that when we do that, there's a possibility that you may have to have the restoration remade. In this case, fortunately, we didn't have to. So we can see that we created this flat root surface. And that means that the portion of the root above the presumed CJ is going to not extend outside of the gingival housing. This is a very important aspect of the protocol, okay? So this is really, really important. So you can see the comparison of where we were in terms of the root prominence to have how much root prominence was reduced by odontoplasty and restorative recontouring, you can see we did quite a bit, and that's really the key for this kind of outcome. Then we're going to have, on the other side where there's composite restoration, again, relatively in a bulky cervical contour of that composite, we flattened it. Any restorations from the CEJ apically was removed to create a flat surface of the root that did not extend at all outside of the gingival housing. A lot of odontoplasty and removing the composite, same in the central incisor area. One very important area is the line angles. You want to bevel the line angles. You see the line angles, we bevel them, and what does that do? It encourages tissues to grow in here. So if we did nothing, we didn't do any procedure, I just stopped at this point, I bet you we're going to have some root coverage. Okay? So this is the secret aspect of the secret sauce. So the odontoplasty and recontouring of restoration. So we've done the subperiosteal tunneling. Now we will coronally advance the gingival margin, okay, and anchor the gingival margin to the teeth using flowable composites that bond these sutures to the teeth. This is really important. See, those of you who do bone augmentation, you're putting fixation screws, you are stabilizing the bone graft. Why don't we use the same approach for soft tissue grafts to stabilize things? Because if the tissues are moving, you're not going to get true regeneration. So we need to, as the surgeon, take full control of the position of the gingival margin. So you see, we have created that. But did we do a good job? Well, we look at this papilla and we see the circulation in it looks perfect. It doesn't look disrupted, okay? Which is what we want. But then look at this area. It looks like I had too much tension as I was coronally advancing the tissue, maybe pulling on that suture too much, and it created a tear. So we have to be careful with that. How? Well, as I'm coronally advancing the gingival margin with the sutures, I usually put an instrument through the vestibular tunnel and push the tissue physically rather than pull with the suture to avoid this kind of situation. Look at this papilla. It looks like there's a fold that's created. This fold is telling me that I didn't do such a great job elevating that papilla from the underlying bone. So it's not too late. If you see this fold, when you're coronally advancing the tissue, reach in there with an instrument and release it. This is what you want to create. A gingival margin on the midfacial that is at the same level as the interproximal, and it has good circulation and not too much tension that creates tear around the tissues. This is exactly what we want. So now we can place our graft material in there. We could use an allograft, we can use a xenograft, we can use an autogenous graft. We don't have a lot of time into getting into this area, but I'll describe a little bit more about material selection. So then the next step is you basically position the graft. You see, we kind of try to do a little bit more release at this point, okay? And then I would say we had pretty big anadental black triangles. We're gonna go to the tuberosity. I'm gonna harvest the tuberosity tissue. Tuberosity is the tissue that is the problem solver. The bigger the problem, the more I would rely on tuberosity. I take the whole tuberosity tissue, de-epithelialize it, divide it into 3 pieces, and I stuff it in each of these anadental areas. But how? We need to use lasso suturing to bring this little tiny tissue in the interdental area and stabilize it and coronally advance it, you see that, and bond it so that it remains stable. So I did the same for each of these lateral incisor interdental tissues as well. So we basically trying to increase the mucosal thickness with using this matrix dermal here, and then feeding some of this tuberosity, which is dense connective tissue in the interdental areas, to maximize our ability to fill the spaces. And this is how the patient comes in for suture removal, which is 3 weeks later. We want to leave these sutures for 3 weeks. What do we see? Beautiful healing, right? This is what you want to see, is that the blood supply should allow for very good healing. Because if you have too much ischemia, it's going to cause necrosis. And if you had incisions in those papillae, you will see papillary necrosis. So that's what you want. The consequence of not making those papillary incision is that we're going to have better tissue healing. Take a look at how big those interdental embrasures were. When we look at the initial healing, we have 100% root coverage. Well, maybe not 100%. You could see a little bit of interdental CEJ area, but compared to what we had as these huge black triangles, we did a pretty good job of filling it. So basically, I could stop here and make you believe that we could do miracles with interdental papilla regeneration. But my dear colleagues, that's not the truth, because we need to do more than that. We need to follow these patients longer than that, not just 6 months, for years. See what happens. At 3 years, we could see that the interdental tissue shrank. We have black triangles there again, okay? Maybe the size of the black triangle is not as much, but my dear colleagues, soft tissue augmentation is not capable, I don't care what technique you use, of reconstructing papillae for you, because papilla loss it requires interdisciplinary care, because some of these open embrasure spaces are there. In this case, because there was significant interdental bone loss, there's only so much tissue bulk you can create in the interdental area without the bone support. And it's not possible to create the bone underneath it with horizontal resorption. But we can use orthodontic treatment, perhaps reducing the size of those embrasure spaces and making the black triangle smaller. If needed to, the orthodontist, in this case, actually Dr. Javiana, the GP in this case, did the ortho and did a great job, but could have brought them a little closer together to completely, eliminate the black triangles, but made them much smaller and more aesthetic. So what we look for is our primary objective is to increase mucosal phenotype thickness, because that's what's going to be conducive to stability of the tissues, and that's something that remains stable. But by reducing the embrasure spaces, we can reduce the black triangle spaces. So it's going to be an interdisciplinary approach. I mentioned to you that we make subperiosteal tunneling. That's very important, because when you compare partial thickness to full thickness flap, traditionally, most of the soft tissue augmentation techniques have used partial thickness flap, okay? And we think that full thickness flap is a risk, but when you look at this split mouth design, it clearly demonstrates that there's higher degree of complete root coverage when full thickness flap was utilized. Why? According to the authors, is that preservation of the periosteum as part of the flap may be the most important factor for achieving complete root coverage. You want to keep the blood supply of the periosteum and the mucosa together. By doing partial thickness, you're cutting a lot of vessels out of the area. Also, comparing tunneling versus coronally advanced flap, better results for tunneling. This is a study done by Dr. Shoko Sato when she was a resident as her master thesis project. She hasn't published it yet. At some point, hopefully she will publish it. But she found that when you look at her co-residents doing different procedures, VISTA, coronally advanced flap, or intracellular tunneling, there was higher percentage of root coverage achieved with VISTA than other techniques. Okay. So when we published our results back in 2011 of using VISTA, at the time we were using the different technique. We did still the vestibular incision, subperiosteal tunneling, and at that time I used a collagen membrane. This was a non-cross-linked collagen membrane that was placed in there, and I coronally advanced and used a platelet-derived growth factor in there. And you could see that at the end of it, we did a pretty good job of coronal advancement. The tissues have very good circulation. And then you could see the 6 months results. So we published the earlier results, but now we have 10-year follow-up of the same patient showing very successful root coverage. Part of it is because we manage several of the risks. So the technique works. This is Dr. Seiko Min, who has done this long-term follow-up of VISTA root coverage to look at how much thickness gain we have. And what he has demonstrated is that you actually get quite a bit of thickness gain with VISTA. Why with VISTA you get more thickness gain? Because as you're coronally advancing the tissue, it creates a fold of the tissue coronal to the CJ, and that tissue, that fold that is created as a result of the bonded suturing, creates a space, almost 5 millimeter space there, that if you fill it with some form of graft, it's going to lead to significant thickness gain that is going to remain stable for several years. That was the follow-up of this study, which is maybe around 1 millimeter of thickness gain. That is quite remarkable to see that we have so much thickness gain. So for material selection, we have different options. We have option of autogenous tissue. Tuberosity, in my view, is better than palatal tissue. I rarely go to the palate these days. I often go to the tuberosity, but I use it usually in conjunction with some form of a scaffold, either an acellular dermal graft or some form of a collagen that is either native collagen, or more often today with the advent of more cross-linked collagen matrix that creates a very nice thickness and bulk of the tissue that is very much beneficial. There are also growth factors in there that we can use, but today I'm less likely to go to growth factors because we have a beautiful natural growth factor in the form of platelet-rich fibrin that has patients' autogenous growth factors derived from their blood that could be used for augmentation. Today, I would use maybe this particular type of a collagen matrix. This is a cross-linked or cross-linked by more natural means for creating bulk in the tissue to create the kind of thickness that we need to create to give us the bulk. This is fiber guide as a material. There are not too many materials like that. You can see that you can create the bulk, or you could use an allograft. So regardless of whether or not we use autogenous tissue, I would always use one of these matrices. And today I'm using PRF a lot. So this is using VISTA with a collagen matrix. At the time, we only had the non-cross-linked form. And you see that with VISTA, we are treating the whole mouth. Now today, we have to deal with different scenarios. This patient, actually, when she came in for consultation, she had seen multiple patients who said you're going to need 5 or 6 different surgeries because they were going to take palatal tissue and do sextant surgery for maxillomandible. VISTA is a technique that allows you to do full mouth treatment. I did maxilla and mandible in one session. Now, this is more relevant than ever for us because in the day of the COVID pandemic, when we go back to our offices, we cannot bring patients back 5 or 6 times because the amount of time that it takes to mitigate the risk for each patient is too long. I think one of the things that we have to look at is to do more one session scaling root planing of the whole mouth, one session osteosurgery of the whole mouth, one session soft tissue grafting. The number of times that we bring the patient back and we do aerosol producing types of procedure should be limited because it takes so much time to prepare for a patient and mitigate the risk after the patient leaves that we want to do all of that all in one session. So VISTA is one of those techniques that allows you to do the whole mouth in a single session, and that's what we did. But what I want you to see is that sometimes what you see in the early days, don't go in too early to try to correct it because you can actually see that the tissues continue to grow, and we see on a very consistent basis a phenomenon called creeping attachment. Part of it is because of the odontoplasty and the shaping of the roots that we created that makes it more convenient and more conducive to root coverage. Okay, so that's something that we want to take. So when we look at different materials, we can look at, these are clinical cases that were published, a case series using 3D imaging and measurement of the amount of thickness gain that we were able to achieve with periodontal root coverage using VISTA. This was published last year. When we compare the results with palatal tissue, tuberosity, alloderm, and mucograft, in terms of thickness gain, basically a millimeter from the CJ or more apically, you could see that there's really no difference in what we are able to achieve in terms of thickness gain using different materials. And the difference here is because when you use VISTA, you coronally advance the tissue and you create that fold right near the CJ, it already creates the space for us. So it really is become less important what material we're using, the more, you know, let's say tissue substitutes that we're using, we can take some really thick tissue to place in there to create that thickness gain for us. And that's going to work. So there's not that much of a difference. Also, I promised we're going to talk a little bit about bone augmentation. And for a couple of minutes, I'll just show you one case where we can also use VISTA for GBR. This is a patient with severe defect around these incisors. You can see bone loss almost to the apices of these incisors in the mandible. The patient has very thin tissue. So one of the major risk factors that we have for GBR is graft exposure, membrane exposure, because the tissues are so thin, and especially in areas such as the anterior mandible, where there's a lot of pull to the site, we need to be very careful with that. So by using VISTA, we can minimize the possibility of graft exposure down the line. So we did extraction of those 2 teeth. I'm using a vestibular approach and then subperiosteal tunneling. And with the subperiosteal tunneling, again, making a remote incision, subperiosteal tunneling to access the areas and allowing us to expose the recipient site and remove all the soft tissue remnants. but also we can do everything else in other areas as well. We can dissect posteriorly to use the VISTA for root coverage in the posterior areas at the same time as what we're dealing with the anterior area. We can also use our vestibular approach for harvesting autogenous bone from the symphyseal area using this kind of a harvester. And then we can install some fixation screws. We can put our graft material. This was a xenograft combined with autogenous graft, combined with PRF, and use these fixation screws to stabilize the membrane. And you can see that we can create a lot of bulk of tissues because the graft remains protected because our incision site was remote. This is not my idea. This well before I started, Fuad Khoury and Michael Block were using this kind of a vestibular tunneling for bone augmentation. And I learned a lot from their approaches to use it for bone augmentation because it works. So we can also use it for treating peri-implant defects. We don't really have time to go over that, but we can go into more depth in our in-depth sessions to talk about how we can manage these types of peri-implant defects. So what we are doing now, we are actually realize that most of our colleagues, we had many courses at our institute that colleagues would come in and do these hands-on workshops and learn the different techniques, but everybody's confined to home. So if you want to learn some of these techniques, we have online workshops. The way it works is that if you register for these workshops, we can send you all of the instruments and the model and supplies that you need for the workshop. The lectures will be partly online, part of them will be live, and we'll have opportunities for interaction for smaller group settings. And then you'll be able to conduct the workshop on the models that we send, on the material we send. And this is available both in US and Europe, maybe also in Asia. We'll introduce this program soon. And you can go to our website, learn about these, learnvista.com, and look up these types of protocols. So with that, I want to thank you, my dear colleagues, for tuning in this hour and spending time with me. It's a pity that I can't see your faces. I can't, see you and greet you in person. Hopefully soon, this situation will resolve. We have an opportunity to meet up at a meeting or somewhere. And I would look forward to catching up with you. I really, I'm so honored to have so many friends and colleagues around the world. I know that many of you are joining from different countries, and it's really a pleasure that you were able to join. Some point that I have for you is that, this crisis will be over. It may seem so bleak right now, it may seem so hopeless right now, but I can guarantee you, at the bottom of this darkness, after we come out, this period will be succeeded by the most, intense period of innovation and growth that we've ever known in humanity. Every time we get challenged, we do more. Sometimes when we get comfortable with where we are and how we are doing, we stop innovating, we stop growing, we stop developing. But this is going to be a stimulus for all of us to let us know that now we need to work harder and make us understand that we cannot do it all by ourselves. We see how interconnected we are. We see how we need each other to get out of this crisis, and we're going to need each other to grow, and it's going to happen. So it has been my pleasure. I'm happy to answer any questions. I will look at the Q&A session. So if you have any questions in the Q&A, you can submit that, and let's see what questions we have. All right, so I have question from David Schwimmer. What type of burrs are used in preparation, numbers, and plan? I use a number of different instruments for root preparation. I use rotary instrument, which is basically I use Brasseler, football shape, finishing burrs, multi-fluted burrs, and flame shape, thin, but the more multiple fluting, the better. I also use piezo surgery as an ultrasonic. I find that whenever you use ultrasonics, you create less damage to the tissues. One thing I should say is that I do the tunneling first and then use the ultrasonic instruments on the roots because the tissues can be retracted more easily. Next question is from my dear Sarah Saifuddin. Hello, Sarah. The question from Sarah is, if patient will get laminate veneer, some restorative dentists prefer to restore first before coverage. So what would be the sequence of restoration versus veneer? I would say that it's best to do all the soft tissue augmentation first because you want to create the basis. And I would do it in 2 phases. I would first coronally advance maximum amount and create the maximum amount of thickness that we can. And then I would wait a minimum of 3 months. And at that point, I will ask the restorative dentist to create a diagnostic wax up to create the desired contours. Because at that point, you may actually need to remove some tissues to create the right contours and then go with the restorations. Some of the colleagues want to make thin tissue because they say it's more aesthetic. I'm attracted to big, fat, thick tissues because I know that it's more stable. Okay, we have, what are we beveling? Okay, the question is, what are we beveling when we bevel the roots? So if you think of the roots as the root prominence, the line angle of the roots, the dentine, has what prevents the tissues from growing into there. So you want to put your instrument right at that line angle of the tooth, the finishing burr or whatever instrument you're using to bevel that line angle, and that encourages tissue to grow in more. Roxanne, hi Roxanne, I see some questions from you. Can you comment on the post-operative operative complications needed to VISTA technique? Okay, so Dr. Lowenguth is from Rochester, and she's a dear friend, periodontist, great periodontist. So the question is, what are the complications? Complications, there's no procedure that doesn't have complications. Post-operative infection, relatively low, but it does happen. When I see the most complication is when I started with a patient with really thin mucosa, usually in the anterior mandible, and when I did the tunneling, maybe I wasn't so careful and I caused some surface laceration of the tissue. So when I got done, maybe the tissues were a little bit lacerated and not 100% preserved. Those are the cases where the patient has a propensity to have graft exposure. So in those cases, I would not use an allograft because allograft has more chance of getting further exposed and having, more difficulty in that. I'm more likely to use PRF. I'm more likely to use autogenous tissue. I can use the one tuberosity and get enough tissue from the whole arch. So we will teach those in those courses. But if I am to use a biomaterial, I'm more likely to use collagen-based materials because they tend to resorb a little faster, less chance of exposure. Roxanne's other question is, can you comment on the post-operative? Okay, now we answered that also. What is the percentage of complete root coverage versus the pinhole technique? Well, the reality is that we haven't really seen results done by the pinhole technique because it hasn't been published. So we don't know that. I could tell you that we have some studies. I will show that for you. This was a study done by several very talented young residents who did this analysis of root coverage technique for the cases done in my clinical practice using VISTA, using various graft material, up to 10-year follow-up of some of these cases. And you could see that the mean root coverage is above 100%, and it actually, you get creeping attachment during the initial phases, and it kind of comes down, but it's usually, the mean is around 100% or a little bit more. I shouldn't mislead you to say we get 100% in every case, but as a mean, we're getting that. The reason is that some of these cases we're getting 120%, 130%. Why? Because with the suturing, we're going further than the CJ. So after that, we end up with the tissue covering the enamel rather than having some residual exposure. But, you know, not all of these techniques have been published. Dr. Lee, Hassan Ali has a question. How do you raise the papilla, and do you raise it also on the lingual side? So the papilla elevation, when we're using the VISTA ABC instrumentation, there are instruments called the C instrument. The C instruments are actually papilla elevators. They're intended to get right under the papilla and elevate it from the bone. So there are like a hook-shaped instruments that go from the vestibular side to the papilla and elevate that. Typically, it's not necessary to reflect the lingual papilla, although we've adopted the technique and use it on lingual VISTA technique. There were a couple of publications last year, one by John Doe and one by a group from Portugal who published on using VISTA on the lingual side. So it is possible to do that as well. Dr. Sylvia Lim, factors to consider for location and amount of vertical incision. Okay, the important point is that when you make a vertical incision, not to come too close to the gingival margin of adjacent teeth. Why? Because when you bring your incision too close to the gingival margin of adjacent teeth, you risk tearing that tissue. So you want to make sure that when you make the incision too close to the gingival margin, it should be at least, the incision should be at least 5 millimeters away from the closest gingival margin, because when you get too close, this area could rip and tear. So 5 millimeters away, and apically depends on the vestibular depth. You can go as high as you want. There's no limit there, but you would do as you need. Also, it's perfectly okay to add multiple incisions. So if you're going further back, you can start with one incision and add more incisions to do the tunneling. But also, sometimes you do add incision just to add graft material. So let's say if I want to make sure that I'm adding graft in the molar area, I don't mind making a vestibular incision in the posterior area just to be able to tuck under the graft material for there. Okay, and let's see. Is the rotary autologous bone harvested available? The rotary bone harvester that I showed you was being sold by Piezo Surgery. It's off the market now. We're going through some FDA documentation. It's right now on back order. Hopefully soon we'll be able to come back with that. Another attendee without the name said, for multiple recessions, for deep abfraction, do you need to restore before surgery? This is a very good question, because we know from the studies that when there's an abfraction or when there's a step in the tooth, it reduces our ability for root coverage. Some of our colleagues in Italy especially have published restoring that the abfraction first with either composite or glass ionomer and then doing root coverage. I tend to not be so gung-ho on putting any restorative material on the roots. I know you can find studies that show you that you get attachment on this restorative material, but those studies are done on pristine materials. If you go back to restorations that are on the dentine, you always see some leakage around the dentinal portion, and that could cause you to have failure. So I don't like to put restorative material on the roots. How do I suggest for patients to maintain oral hygiene during the healing period? I use ultra soft toothbrushes. I like the toothbrush from a company called PHB and also from Tepe. They have excellent post-op toothbrushes that are really, really soft. I would give that to patient and they start brushing immediately after surgery. They're really, really soft and they don't traumatize. Typically, I don't have them floss until after I remove the sutures, but I have them use chlorhexidine in the meantime. Okay, and then Dr. Chan 9, any limitation for VISTA? Yeah, so VISTA, if you have, sometimes it's difficult to perform the VISTA, especially, let's say, in the mandibular posterior area. You always want to make your incision anterior of the canine, not to, you know, damage the mental foramina and the mental neurovascular bundles. So the limitation is you can't make your incision in the premolar area, but you can make it anterior, that tunnel for posteriorly. Also, when there's a lot of scar tissue in the vestibule, especially when the patient had previous free gingival graft, it's just more challenging, but it's not limited. But where I find the biggest challenge is where we have really, really tight embrasure spaces, especially in the mandibular anterior, where we have the mandibular incisors and have a lot of root proximity. It's really hard to elevate in those areas where you have very small interdental tissue, so you could end up ripping that interdental tissue. So sometimes when you're working in those areas, you end up with papilla elevation. That's basically tear that was unintended. Dr. Vikander Singh has a question. Didn't you get clear advantage over intracellular tunneling? Please clarify. Well, intracellular tunneling is a great technique. I know some fantastic clinicians who use intracellular tunneling and have beautiful results. But the question I ask is, if you are going to create a tunnel, what is easier? To go through the small, you know, sulcus of the teeth, or through a large vestibular access that allows you to get the instruments in there? So personally, I prefer to use the vestibular access, but if you're really good at intracellular tunneling and you're excellent at it and you're getting great results, there's not only one way to do something. Yeah, there are many different ways, and by all means, go ahead with that. So Dr. Khalid Hossein has a question. Let's see, thank you for the lecture. Do you have suture the graft? Okay, so when do you suture or not suture the graft? If I have a large graft, okay, let's say the graft that I use, for example, in this case, which was a very large, you know, graft. Let's say, if I can show you that. This is a very large, you see that this is an allograft, very large. This graft is not going anywhere. It's going to fill the entire tunnel and it's going to be very stable. So there's no need to suture this. But if you have tiny sutures, just like I showed you here for the subperiosteal, for the interdental areas. So you have these small tuberosity grafts. These are going to move around and shift. So you want to suture those. We use a lasso suturing to suture them in place. Does a cellular dermal graft have creeping attachment? I think that the creeping attachment is independent of what kind of graft we use, because it's actually more dependent on root shaping that we're creating. It encourages the tissue to grow in there. So I believe that creeping attachment can be more predictable and more commonplace if we do two things. One is that we actually create a concavity of the roots, or actually eliminate all the root prominences to encourage the tissues to grow in, kind of like platform switching around implants, right? You can do that. Platform switching encourages the tissues to grow in. We make our roots platform switched. And then the second thing is we create a lot of thickness. If you have thick tissue, it's more likely to grow in there. So we can make that more predictable. We have, let's say, question from Dr. Swati. How are you suturing the endodental tissue? That's what I showed you with this kind of a graft with the lasso suturing. For the mandibular defects, how do you manage the area close to the mental nerve? Incision has to be always anterior of the canine, and the tunneling doesn't go posteriorly. You never want to go directly posteriorly in the vestibular area. The tunneling goes directly under the attached gingiva, and you only will dissect the attached gingiva from the underlying bone, because if you do that, it's safe. You don't want to go directly in the vestibular area. Okay. Dr. Ashraf Babur, thank you for, okay, so let's see. Replace the material, other material, okay. The question is, what a sequence of suturing versus graft placement? I like to always suture, stabilize the tissue, create the tunnel, create the space, and it's far easier to slip the graft material after the stabilization of the suture. Dr. Ramsey Radisi, do you use apical periosteal suturing? No, because I want to suture not apically, but at the cervical area, because the cervical area is the area that I want to stabilize, and I want to stabilize it directly to the teeth. What good does it do if I stabilize in the apical area and I don't have a fixed structure in the apical area to stabilize too? So I prefer to do the cervical stabilization. Do you have, can you short resorption collagen such as color tape? No. Color tape and those products are going to resorb really quickly. There's really no benefit to putting in there other than just causing a lot of inflammation. So I wouldn't recommend that. Okay, Dr. Mark Good. What burrs do you use for porcelain metal reduction? I would use the diamonds. I would use the coarse diamond to start. I would use a round coarse diamond to start the reshaping, and then I would go to finer type of finishing burrs. Dr. Sanaz Yousefi, if the patient needs ortho, do you recommend VISTA before, after? I usually like to do before, because, you know, I actually started doing a lot of Invisalign and clear, you know, aligner therapy, because before I would tell people, if you're planning to move the teeth lingually, do the ortho first and then do the root coverage. If you're planning to move the teeth buccally, do the root coverage and the soft tissue grafting first. But once I started using Invisalign, I realized that almost always the movements are very complex. The teeth are moving, you know, facially, lingually at different phases. And I think it's always better to augment the mucosa, convert the patient with thin mucosal phenotype to make them thick, and that will reduce the risk of recession defects during treatment. Dr. Shebi Mehrazian, how do you deal with patients' complaint, suture hanging on the teeth? Well, you know, do patients mind that they have bonded sutures? Yes, but you know, patient who has a lot of recessions, having a lot of roots showing, they're motivated to do something about it. Yes, you go through an anesthetic period where you have bondings during that 3 weeks, but we also, I showed you these sutures are polypropylene sutures, 6O, which we typically use, but we also have some PGCL monofilament sutures that are clear. So if patient really objects to showing the blue, you can use a PGCL clear monofilament sutures so it doesn't show. But most patients, we let them know that you have to go through this interim period. Dr. Danish Barmer, tunneling at remote site to add bone without membrane. Okay, so if you're tunneling remotely to add graft without a membrane, I wouldn't advise that for GBR. Again, the principle of augmentation is stabilization, where whether you're doing soft tissue or bone, you have to stabilize. So if you're using remote tunneling like VISTA and doing bone augmentation, I always install fixation screws and stabilize that very well. Now, do you have to always use a collagen membrane? No. Today, I'm using in many of these cases, combination of a PRF and a bone scaffold. And then when we combine the two, it makes for a very dense kind of a PRF block. And we cover it with PRF solid matrix. And that makes it a lot easier. Dr. Al-Mumadi asked a question, can you explain more about the rotary instruments? The rotary instruments are not available right now, but basically they're kind of like a trephine and they collect particulated bone inside. Veronique, hello Veronique. I'm glad you were able to join, Ben Hamou. And you have a question, have you seen cases it looks like bone is growing when you use PRF? Is it just, your question is, if we're using PRF for soft tissue augmentation and we see bone is growing, or when we're using with GBR? Because with the GBR, PRF itself is not an osteogenic growth factor, because most of the growth factors that are in PRF, they're mitogenic, they are recruiting, they're angiogenic, and they don't actually grow bone. So usually I combine that with autogenous bone to have some of the BMPs and other growth factors that are part of the osteogenic elements of the autogenous bone. Dr. Mohammed Rashad, for GBR with VISTA, do you use membrane or solely rely on the periosteum? I use both. I use either collagen membrane in some cases, but in other cases, I would use a PRF combination, but always with some kind of a fixation screws. Do you have inferior results in smokers? Yes, smokers have inferior results with every aspect. They have diminished wound healing. They have more chances of complications and less chance of root coverage. Dr. Hassana Lee asked, do you use dexamethasone injection? I do not. I used to use dexamethasone before I started using PRF, but since I'm using PRF, no more steroids. And PRF does the same thing and is safer with less complications and less side effects. Dr. David Ting is asking, desensitizing use prior to coronally advanced tissue. Okay, root sensitivity. I honestly get very little root sensitivity problem with VISTA. Part of it is that when you look at the amount of odontoplasty that I get, that I perform, most people think you're making your patients incredibly sensitive. And the reason that we don't is because I only will perform odontoplasty in areas where I'm confident I can cover. So if the root is so far outside of the gingival housing that there's no way to bring that root within the gingival housing, I wouldn't even try the odontoplasty. But if the root is, you can bring the root within the gingival housing. If you can bring the root completely within the gingival housing, you can cover it. Let's see the other question. MRC on teeth taken into consideration, or simply just advance the tissue. Okay, so the question is, would you know, how much recession do they have? Do you take that into account, or you bring the tissue 2 millimeter coronal to the CJ? I would try to coronally advance as much as possible. Ideally, I would bring the mid-facial tissue at the same level as the interdental tissue. So sometimes it may not be possible to bring the tissues 2 millimeters coronal to the CJ, especially in cases with advanced Miller class 3 or RT2 class recession defects where we have severe interdental bone loss. In those cases, you can't bring them over to the CJ. What I try to do is to try to bring them at the same level as the interdental tissues or more, as maximum possible. Okay, and Dr. Kelvin Gohan, are there any contraindications? As I mentioned already, root proximity could be potentially a complication. Dr. Kim Young Jong, can you make a comment on possible scar formation at the incision site? Yes, you can get scar formation at the incision site, but usually the incision site is in the vestibule. You typically won't see it. But one thing that I should say is that when we make our incision in the area of the, when we're doing VISTA and we're doing tunneling, the question is, what does it do to frenum? It eliminates frenum. So I never touch the frenum after VISTA, because when you will see is that you get the attached tissue there, even if you don't do anything to the surface frenum. So we don't touch the surface frenum, it will go away. How long before they go back to flossing? After, you know, I would say after we remove sutures, where we tell them not to compress on the tissues with the floss. So let's see, Dr. Behtad Javadan, on what are your thoughts about mucograft? I use mucograft routinely before. I am using FibroGuide, which is the more cross-link form of it, more common today. Dr. Chen Nayan, let's see the question. Can you use VISTA in thin tissues and exostosis cases? Yes. Well, yes. Exostosis is actually an excellent situation for VISTA, because if you have exostosis, it's impossible to create an intracellular tunneling. It's impossible. You cannot go over the exostosis from the sulcus of the teeth. So it's much easier to go from the vestibular side over the exostosis than otherwise. And yes, with a thin tissue, it is challenging like with any other technique. No matter what technique you use, patients with thin mucosa are a challenge, but at least with VISTA, you have a chance because you have a wider access and you're going more apically, so then less chance of trauma to the gingival. Dr. Ramsey Radisi, do you mean the, what is that? Sorry. Do you use PRF? Yes, I use PRF. I use two forms of PRF. I use the solid matrix PRF, and I also use the liquid PRF. I typically use liquid PRF to basically reconstitute all of the matrices that I use, whether you use collagen or dermal tissue. I will reconstitute it with liquid PRF, and then I use solid matrix PRF on top of that. My dear friend Ziv Mazor, hi Ziv. Have you used Volume Max as material? I don't have experience with Volume Max, but it's basically similar in concept to FibroGuide. So I've used FibroGuide, but I don't have experience with Volume Max. It has the ability to partially ossify. That's really interesting. I don't have any specific interest about that, but I'm very interested to see what your experience has been, Ziv, with using Volume Max and seeing bone regeneration. I wouldn't be surprised if you have a large matrix that creates the space there. If you have a protected space, you could potentially get some mineralization into that space. What suture types using for coronally stabilized flap? For the suture specifically that I use in these cases is a 6-0 polypropylene with a C3 or P3 needle. That's the most common. I sometimes use a 7-0 if there's not a lot of tension. And I use sometimes the PGCL monofilament suture that is clear. It is resorbable, but it stays in for at least more than a month before it starts degradation. Dr. Swati Kejriwal, are you suturing the interdental tissues? Only if I place a graft in the interdental tissue, I will suture that. Can you go over the lasso suturing? The lasso suturing means that you start out wherever you want the tissue to end up from the exterior. You go from outside in, and you go through the tunnel, and then you go through the graft, and you go back through the tunnel, and you exit from near the same area that you want the graft to end up. So the entry and exit point of the suture from the mucosa or wherever you want the graft to end up. When you pull the suture, that makes a lasso and basically tie the suture in that area, and the graft ends up where you want it to be. And Dr. Lowenguth asked the question, do you take CBCT for the posterior mandible? Having the CBCT is incredibly helpful because that shows you the position of the mental foramina. But in this situation, if you can see the mental foramen, you're not out of the woods. Because with implants, you don't want to go into the mental foramen or the mandibular canal. But with vestibular tunneling, you don't only care about the foramen, you care about the neurovascular bundle that fans throughout the tissue. The neurovascular bundle is distributed in a fan-like fashion throughout the submucosa. So just because you know where the mental foramen is doesn't protect you. The key is subperiosteal tunneling. If you're performing subperiosteal tunneling, you're keeping the mucosa and periosteum together, and the neurovascular bundle that travels to that the submucosa is protected. The key is going to be to make sure that you don't run with your instrument at the position of the mental foramen, and you could do that by just going right under the attached gingiva and traveling posteriorly. As long as you keep your instrument, wherever you're keeping your instrument in contact with bone, limited to attached gingiva, you're going to be completely safe and you're not going to cause any trauma. And then the question is, all right, if you raise, required to start the incision at the mucogingival junction, attached gingiva, or mucosa, or anywhere. So the question is, should your incision start at the mucogingival junction or attached gingiva? It doesn't matter. The reality is that most of the time, the vestibular incision is going to be in non-attached and movable part of the vestibular mucosa. So does it matter if it comes in the keratinized tissue or not? No, most of the time it will not, but the key is don't get closer than 5 millimeters to the teeth. Dr. Mark Good, what burrs used for porcelain reduction? Okay, we talked about that already. You use the diamond burrs for that. Dr. Dean Ahmad, hi Dean, I missed you. And what dental codes do you use for billing? Honestly, I don't know, but if you're using a connective tissue graft, you can submit the connective tissue grafting bill code. But if you're not, you can use the pedicle code, because any kind of coronal advancement could be considered the pedicle grafting. And then if you use other biomaterials, you can use the biomaterial code. Technically, wherever you're doing a full arch or large area, you can bill for any non-continuous teeth. So if you have 3 teeth, you can bill for 2 procedures as long as the 2 teeth are not adjacent to each other. But practically, if I do a full arch, I usually charge for anywhere from 3 to 5 of the most severely involved teeth in that area. And what advantage? Oh, Daniele Cardiarapoli. Hi, Daniele. Greetings to you, my friend. Do you have, okay, let me show you Daniele right here. I have your book right here. I have Daniele's book right here behind me. So beautiful book. I highly recommend that. Okay, Soft Tissue and Pink Aesthetic. So that's Daniele's book. You can pay me later, Daniele. What was your question? I missed, I forgot the, okay, here's the question. Let's see. When do you use fiber guide and do you use full thickness? Yes, I use full thickness of the fiber guide. Fiber guide is 6 millimeters in thickness. I know many colleagues thin it out and they divide it, split it in half, they bevel it just like a block graft, they shape it. But you know what? If you're gonna be cutting the fiber guide, if you're gonna be, you know, throwing it half of the way, mail it to me, I'll use it. Because that's expensive material. You don't need to be thinning it. The whole benefit is to use that thickness. When you use this kind of a coronal advance with VISTA and you bond the sutures, you get exactly anywhere from 5 to 6 millimeters of space there. So that 6 millimeter of the fiber guide fits perfectly into that space, and I don't bevel it at all, because you want, if you create that protected space and you fill it, you're gonna create maximum thickness in that area. Okay, let's see. We have a question by Dr. Fernando Rojas. Hi, Fernando, my dear friend. If you're planning to restore with veneers or crowns in the anterior area, better to do the crowns before or after VISTA. I would recommend to do the soft tissue augmentation first and then do the crowns afterwards, because you want to clearly define the proportion of the teeth that you want. So I would do maximum coronal advancement, cover as much of the roots as you can, and sometimes you may end up having too much root coverage that may not be aesthetics, but you can go in and do the contouring that you need and then make your restoration. You have much better results. Again, Fernando has a question. If you plan, let's see. Oh, it's the same question, duplicated. Dr. Vinita Goyal, do you prescribe antibiotics and which ones? Yes, I routinely use antibiotics. I would prefer amoxicillin as the #1 choice. If a patient is allergic, alternatives could be either azithromycin or clindamycin. But typically I have the patient on a week of antibiotics, starting an hour before and continuing for that week. I know in Europe, many colleagues don't use antibiotics. That's fine. But especially, I had a case just a month ago, right before we were shut down, that the patient did not take antibiotics. She came in with some graft exposure. I had used acellulodermal tissue. She had all these exposures. Well, she also had a herpetic lesion. Well, when I looked at that and I said, when did you finish your antibiotics? She said, oh, 2 days ago. I said, well, why? Because you were supposed to be taking antibiotics until today. She hemmed and hawed, and finally she admitted, she said, I really, really apologize. I'm really holistic and I didn't want to take antibiotics. So she didn't take it. So I would run into complications with that. So I had to take out a large part of that dermal graft. So I always put patients on antibiotics. Okay, how can you comment? This is from Dr. Swati Kejriwal. I apologize if I'm not pronouncing anybody's name. I know we have colleagues from all over the world joining about the frenum and scar tissue. Well, the frenum after VISTA goes away. I would highly, highly recommend. I'll show you this case. Actually, you see, oh, I just should have shown you here. This is the case, okay? I didn't have a really prominent frenum, but you see the frenum goes away and you get attached tissue. And the reason is that because you have a subperiosteal tunneling and you're placing the graft under all of those elastic fibers, you get a tight attachment to the on the dental side, on the alveolar bone side, so you get a tight attachment. So even if the surface mucosa is slightly movable, nothing is attached in these deep layers with the elastic fibers. And as a result, the frenum goes away. So be patient with it. You don't need to touch the frenum at all. Okay. Is there any from Dr. Anonymous, any consideration regarding the vestibular depth? Obviously, the patients with shallower vestibule give you less working space, but if you need to, you can extend the vestibular incision as far as you can. What size of needle do you use? I use a P3 or C3 needle for the suture. Let's see. Can you elaborate, Dr. Genuine Sai? Which artificial material do you like most for VISTA surgery? Well, I use a combination of material. Typically, I use whatever material of choice for thickness gain, either a cellulodermal graft or fiber guide. Those are the two materials that I use. And I think they have about equal result, but if the surface mucosa is somehow compromised or if the tissue is really, really thin, I prefer the fiber guide because it has less chance of exposure. But I'm always using PRF today. Dr. Lawai Azizi, how long do you keep the sutures? I would keep the sutures for 3 weeks. Dr. Muhammad Rashad, hi, Muhammad, how are you? Around implants, especially if you have some thread exposed, do you perform full thickness? Do you perform split thickness? Well, I do always subperiosteal tunneling. Partial thickness or split thickness separates the periosteum from mucosa, and as a result, it's going to compromise the blood supply. So there's no point in that. So the only point that we have used for subperiosteal tunneling is that it keeps the blood supply, but the partial thickness or split thickness were sometimes used for advancing the flap and reducing the tension. But you can actually reduce the tension by going inside the tunnel and rolling your instrument through the tissue, and that stretches the tissue and relaxes it. So you don't need to do any kind of split thickness. Okay, is a papillary augmentation connective tissue necessary to add to ADM? So if you're, well, I'm not sure if you really are doing papillary augmentation. Well, you could see in this case, we had quite a bit of a papilla or interdental tissue fill. I would never commit to a patient that we can fill or regenerate the papilla because it's not a predictable procedure. If a patient has large embrasure spaces, black triangles, I would say the treatment is multidisciplinary. Soft tissue augmentation, and the most effective tissue is the tuberosity tissue. Number two, the ortho, by reducing the embrasure spaces to kind of squeeze that tissue in. And in some cases, the reason that the patient has such big black triangles is because they have really triangular shaped teeth that have point contacts at the incisal edges. So patients may need to have some restorative changes in those areas as well. Dr. Vinita Goyal, what do you do with exposed alloderm during PO checks? Okay, if you have any exposed graft material, if there's no purulence, there's no suppuration from that area, I may leave it alone, put the patient on little extended antibiotics, maybe use some betadine around the local site. But if I see that there's any purulence, I will remove at least that exposed part of the graft, or any part that I feel that has been contaminated. I would just use a sharp blade to try to cut out that portion. And then I would use PRF in that space. But sometimes if there's too much purulence in that area, I would just remove all of the graft and replace it with PRF. And surprisingly, many times you end up with significant amount of root coverage anyway because if you keep the coronal advancement bonded sutures, that is helpful. Dr. Sapat Pan Sawang, is papillary augmentation, oh, we already answered that. Dr. Walid Eldomiatri, can you talk about the unique design of the instruments? We can get more about the instruments in the workshops that we're doing. So hopefully you'll be able to join some of those workshops. The instruments, what makes them unique is that they have a very, they have almost like an iPhone. They have the shape of the iPhone and the tip because they have flat with rounded edges, and that kind of, the flat side works like a snowplow under the subperiosteal tunneling. and the instruments have the curvatures that conform really well to the alveolar bone, so they fit very well around those areas. And they also are designed to make the vestibular tunneling. Those are the A instruments. And then to go from the vestibule to the gingiva, they have angulation for crossing from the vestibule to the attached gingiva. And then the C instrument are papilla elevators. So they allow you to do all three of those procedures. Okay, Dr. Saifuddin had a very good observation that the central incisors after ortho were super erupted, and that's what increased the inadental papilla. Very good, Sarah. Very, very perceptive. That is very good. So Sarah's favorite orthodontic movement is intrusion, right? So that would have been a very good step. Dr. Eli Tehrani. Hi, Eli from Toronto. Hi. So thank you for the note. Oh, thank you. Just compliments. I appreciate that. Let's see. Can you advance the tissues without any graft? This is an anonymous question. You can just do the coronal advancement, especially in cases where you have, you know, patients with thick mucosa or, you know, the mucosal phenotype is thick enough. Do you really need to place a graft? Well, you don't have to, especially in those cases. But if I go through the trouble of doing the tunneling, you know, you're creating a space. And that space could potentially be a dead space that if you don't fill it with something, it's going to create a blood clot in there and delay the healing. So I'd rather fill that space with something. You can certainly use PRF, but more often than not, I like to do maximum increase of the thickness of the mucosal phenotype. And as a result, I would still, you know, use some kind of a graft. And Dr. Nilofar Danesh Parvar asked a question. If you're stabilizing the sutures first, then you're engaging the graft with your sutures, then you are not engaging a graft with the suture. Okay, so the question is, if you're first doing the coronal advancement and bonding the gingival margins to the teeth, then if you're placing the graft, you're not engaging the graft with those sutures. That is true. You know, if you're just doing that, the sutures are not, the initial sutures that we placed are not going to be engaged into this particular graft. So if you need to stabilize those graft materials that you put in later, you can introduce them, you can subsequently graft that to the surface mucosa. So you have to use additional grafts to stabilize that. That's true. You see, you have to use additional sutures to stabilize the graft because these initial sutures did not engage into the graft. It is true, but I find that when I introduce the graft first and then put the suture later, it becomes more complicated, more complex. Dr. Joachim Mitchell, how do you mitigate the risk of to gain success? How do you mitigate the risk to gain success? Well, risk assessment is the whole key that we need to, you know, do our risk assessment in all the areas that I looked at. You want to make sure that you look at root prominence, you want to look at mucosal initial thickness, how much tension. Each patient has different levels of tension, and you want to manage each of those risks to be able to be successful. Well, my dear friends and colleagues, I think we got to all of your questions. There were so many questions. And I really, really appreciate all of you. And I can still see that there's still several hundred of you are there with us. I know you connected from so many different countries around the world. I really cherish this time that we spent together. I really wish I could give you a real hug, but I give you a virtual hug. And I really appreciate that so many of you joined in so many odd hours around the world. And hopefully we will see each other in person. But keep your spirits high, stay positive. We're all going to get through this together. We need to be working together. We all are interconnected, no matter country, no matter what personal beliefs we are. We're all in it together. We're all going to advance beyond this period. And I can guarantee you, we're all going to do much, much better in the future. So with that message, I bid you goodbye. And I hope you can join me on Thursday. We have several webinars on Thursday. And we have also another webinar next week, same time, with my dear good friend, Dr. Fernando Rojas Vizcaya on the virtual planning of the smile and how do you plan implants relative to that. So thank you very much and look forward to connecting with all of you again.